Good afternoon, everyone. And thanks for joining us locally in person, and hello to our online viewers wherever you may be joining us from. My name is Carly Turnbull. I'm the Manager of Portfolio and Operations for the Center for Bioengineering and Biotechnology. We call it CBB. Welcome to CBB's third annual conference. It's so nice to accommodate an in-person audience on this International Women's Day. This year, we bring you Waterloo for Health, Technology, and Society. We will discuss the use of technology for accessible care and the safety of said technology. Part of CBB's mandate is to translate knowledge generated at Waterloo and via our collaborators to a community audience. That is our goal over the next 2 days. Keeping our theme and goal in mind, it's important to recognize that much of our work at Waterloo takes place on the traditional territory of the neutral Anishinaabe and Haudenosaunee people. Our main campus, where we present from today, is situated on the Haldimand Tract, land granted to the Six Nations that includes 6 miles on each side of the Grand River. Our active work towards reconciliation takes place across our campus through research, learning, teaching, and community building, and is coordinated in the Office of Indigenous Relations. Accessible care demands availability, affordability, and approachability, among other things. It is important to recognize that there have been systematic barriers that prevent these essential pillars of access for Indigenous and other underserved peoples. Several of our speakers will discuss this further. A few housekeeping items. Washrooms are to your right of the exit, down short sets of steps or via the ramps. Questions at the end of each session may be invited by raising your hand or via YouTube video comment. Now, I invite Waterloo's President and Vice Chancellor, Vivek Goel, to open our event.
Thanks, Carly, and welcome everyone. Welcome everyone watching in online through YouTube. And it's a great pleasure to be here. I would like to start by thanking Carly for doing the land acknowledgement and also noting the challenges that First Nations, Inuit, and Métis people have faced in accessing health services and accessing the conditions that lead to good health. I think it's also important for those of us who've been working in the health system to acknowledge the role that the health systems themselves have played. Researchers have done in doing experiments in different communities, sometimes without consent. And so we all need to learn the history if we're going to live up to truth and reconciliation. So it's great to have this conference, but I'll open it with maybe a much more dismal message, and that's simple. The healthcare in this country and in most societies is unsustainable. We can look at whatever's happening in our local community hospitals across the country. Every day there's stories in the media about the challenges that we face. And there are many facets to that, but the reality is we cannot continue to afford to provide health services in the way we have always done so. The demand is continuing to grow as the population grows, as populations age, and to continue to think having more hospitals, more doctors, more nurses will make health better is an experiment in futility over and over again. And what we really need to focus in on is how do we ensure people are as healthy as possible, not focus in on healthcare and health services. Healthcare and health services are absolutely essential when you're sick or injured, but ultimately what people would like to have is the best life possible in the healthiest way possible. And that entails thinking about social determinants of health, about all the things that help us stay healthy. Second, and I know this will be a big theme of the discussions today and tomorrow, is we have to improve the use of information and digital technologies in health. There's just too much fragmentation, and that really leads to, one, people not achieving the optimal health outcomes, but also not having the optimal health services. We need to support our health workers. And in any study that you look at, you can see that administrative demands, the managing relationships, and so on have been increasing over time. And in fact, technologies that we may think are there to help healthcare workers inevitably increase the demands on their time and take them away from providing good services. And so a really important theme of the conference is how do we make sure that clinical engagement, that patient engagement is in there as we're developing our new tools and technologies. And then finally, we have to think about the new innovations that we're going to bring so that we're not continuing to do the same thing over and over again. And that's what this conference is all about. And whether it's tools that might be coming from artificial intelligence and data sciences, robotics, nanotechnology, quantum technologies, we are at the cusp of a major revolution in health, very similar to the molecular revolution that took place over the previous 30 or 40 years, and things that we're all very familiar with today as a result of the pandemic, PCR testing, messenger RNA vaccines, are the result of the molecular revolution when we understood DNA and RNA. As we think about technologies like quantum and nano, we're going from looking at the molecular level to the subatomic level, right? Molecular to subatomic, and it's orders and orders of magnitude. And so whether we think about imaging or therapeutics, we're going to have very similar, if not greater, pace of revolution in the technologies that we're able to apply to both prevention and to treatment. And so when we go back to how do we ensure people are as healthy as possible, and when they're sick and are injured, we have the best tools available, this is where technologies will come in, and we're greatly positioned here with the kinds of speakers that we have at this conference to be thinking about what that future looks like. So I look forward to hearing about the discussions that happen at the conference. I just want to close by thanking the organizing team, and Carly in particular. It's the third time I've seen her do one of these conferences. They're always amazing, and they bring such diverse talent together. So thank you very much.
All right, our first speaker for today and the keynote address is coming from Dr. David Marsh at the Northern Ontario School of Medicine. He's joining us virtually today, couldn't be here unfortunately. He's on a trip to South Africa right now, but he will be joining us for a Q&A afterwards. So please, as he is discussing virtual care and how that was delivered in Ontario, and especially how Ontario was able to pivot and deliver care in this way during the pandemic, and how we're going to bring it forward to make sure that primary care is available for all people. Please think of your questions, and we'll invite you to raise your hand at the end so that you can engage with our speaker. All right, I turn it over to Dr. David Marsh.
Hello, everyone. My name is David Marsh, and I'm glad to speak to you today about virtual care in Ontario before and during the pandemic. In terms of conflict of interest, I have income from the Northern University as the Vice Dean. I previously was Chief Medical Director for Canadian Addiction Treatment Centres from 2014 to 2022. For which I received a stipend, and my role was to lead quality of care initiatives. and I'm also an adjunct scientist with ICEF North, although that brings me no income. I have no funding from any drug companies or other commercial interests. In order to talk about virtual care in Ontario, I need to set a little bit of background. And one of the important points to remember is the difference between Northern Ontario and Southern Ontario. This is a map of Ontario to scale. Often we see maps where Southern Ontario is separated and taken out of scale. So just want to make the point that you could drive from Toronto to Windsor in 3 or 4 hours, whereas to drive from Sudbury to Kenora might take you 3 days. This area of Northern Ontario has a space of about 800,000 square kilometers and about 800,000 people. And so healthcare innovations that help deal with the geographically dispersed population are important in our context. And virtual care and the Ontario Telemedicine Network originally developed in Northern Ontario as a way of spanning these geographic distances and extending physician services to areas where those physician services or specialties were not available, and to thus avoid much of the patient travel and transport that's required otherwise. This is also part, unfortunately, of the context of Northern Ontario, that many small communities no longer have enough physicians or any physicians at all. And although this sign was posted in Australia, it bears remembering in the Northern Ontario and rural contexts throughout Canada. The other part of the background I want to cover is a little bit about the opioid crisis. And that's because my own research is in addiction medicine. And much of the research that I will show you today of my own has been done looking at treatment of opiate use disorder, including the role of virtual care in expanding treatment for opiate use disorder. The CPSO were among the early organizations to officially recognize that what we're seeing is a crisis in public health related to opiate use. Opiate-related deaths have escalated steadily over the last 30 years. I'll show you a little bit of data on that. Also important for you to understand that methadone and buprenorphine are very effective treatments for opiate use disorder. The WHO has recognized them as essential medications that ought to be available in every geographic area of the world. And they have important effectiveness in terms of preventing opioid-related deaths, reducing HIV risk, reducing the use of other opioids, and improving psychosocial and physical health for the people who are impacted by this disorder. This is an old slide from 1966, perhaps older than many of you in the audience, but it still clearly illustrates the pharmacological benefit of opiate agonist treatment. So in this example, Dr. Creek, Goel, and Niswander, we're talking about the time scale by which heroin affects people with rapid increases in effect and rapid decreases, days when they used frequently and spend most of the day impaired, days when they use less often and spend most of the day in withdrawal, and the constant risk of overdose when people use illicit opioids of unknown purity and content. And as we'll come to later, this risk of overdose has been dramatically increased in the last 5 years in Ontario. Opioid agonist treatments like methadone or buprenorphine, when they're taken as prescribed at an appropriate dose, have a much slower onset and longer duration of action, and maintain the person physiologically in the normally functioning area where the body's homeostasis can be maintained. They're neither impaired nor in withdrawal. And this creates a physiological situation where they're capable of addressing the psychosocial and other aspects of their substance use in order to improve their overall function. I will talk about treatment retention as a key marker of quality of care. And here you see one of the many studies that emphasize the importance of treatment retention. This was a randomized clinical study conducted in San Francisco, where patients either received a gradual tapering of methadone over 6 months, followed by 6 months of enhanced counseling and aftercare, or 1 year of methadone maintenance treatment with the same level of counseling. The group who received methadone for a year rather than 6 months at the end had better outcomes in terms of drug use and illegal activity and HIV risk behavior and lower mortality. The treatment cost a little bit more, but the overall healthcare costs were reduced. And so this is why we look at treatment retention as a marker for a range of other benefits from opioid agonist treatment. This looks at opioid overdose deaths by drug in Ontario from the first decade of this century. And you can see what some of you will remember from the media, that from 2000 until 2012, oxycodone, mainly in the prescription form of slow release oxycodone that was increasingly prescribed, accounted for a large number of deaths and most of the increase in opioid overdose deaths. However, around 2010 and especially after 2012, when the patent on the first slow release formulation of oxycodone ended, oxycodone no longer was the leading cause of death. And we saw gradually increasing deaths related to fentanyl leading up to 2014, 2016. If we extend this same graph out for a few more years, you now see that that increased number of deaths related to oxycodone seems small in terms of the number of fentanyl-related deaths that have increased exponentially after 2015, when illicit fentanyl started to appear in Ontario, and these deaths have just continued to rise to more than double this level by 2020. So we have steadily seen exponential rise in opioid overdose deaths in Ontario and throughout much of North America, going back to the early 90s. Northern Ontario is particularly affected by this. This isn't 2013 data, but in other years, it continues to be the case that when we break down deaths by geographic area, the Northeast and Northwest local health integration network geographies are ranked first and second in the province on per capita opioid overdose deaths. A more recent data looking at opioid poisoning or overdoses presenting to hospital, and the size of the circles is related to the per capita age-adjusted rate. You can see that Thunder Bay and Sudbury are as large or larger than centers like Toronto, Montreal, Vancouver, Calgary, that have gotten much more media attention. Again, emphasizing the point that Northern Ontario is heavily impacted by opiate use disorder and opioid-related overdoses and deaths. The last word about the effectiveness of opioid agonist treatment. Our own research using ICES data has shown that all-cause mortality is reduced by 55% during the time that people are retained on methadone or buprenorphine. Once they drop off medication, the mortality rate quickly increases back to the pre-treatment level. The use of emergency rooms and acute care is substantially reduced, including risk of hospital admission for deep tissue infections. And methadone maintenance treatment is very cost effective. This is data from the methadone arm of the Naomi study, where we tried to provide optimized methadone maintenance with integrated nursing, physician, pharmacist, and social worker care all in the same site. It still only costs just under $4,000 per patient per year, whereas the untreated healthcare costs due to emergency room and acute care were almost double that amount, and criminal costs, of course, were substantially higher. So society, by and large, benefits dramatically in terms of cost effectiveness of opioid agonist treatment, as long as people are retained in care. Urine testing is an important part of opioid agonist treatment, and in this recent study, we looked at the frequency of urine testing and how that was related to treatment retention. Basically, the more often people left urine samples, the more likely they were to be retained in care, with those leaving samples more than weekly being 6 times more likely to be retained in care for 1 year compared to those that were leaving samples less than weekly. And that's important when you start to think about how opioid agonist treatment needed to be adjusted and adapted during the pandemic. So we'll come back to that also later. a word about geography and to introduce these treatment retention graphs. So this is looking at people retained on opioid agonist treatment over time. And this is using data from ICES. So it's looking at all of the patients in Ontario at the time. You can see that the majority of patients are living in Southern Ontario, similar to the majority of the population. And that the gray lines, which are Northern urban and Northern rural groups, have slightly better treatment retention than the Southern urban and Southern rural groups, with overall treatment retention being around 50% at 1 year, between 50 and 60% at 1 year in 2015. So using the same type of technique, and in this case, using data from a single network of clinics, not for the entire province, we looked at care delivered in person versus by telemedicine. So this is the situation prior to the pandemic, when much of the virtual care for opiate agonist treatment was used to deliver care in regions where physicians with the expertise to offer this care were not available. And this allowed treatment to be accessible across all of Northern Ontario, but it did rely heavily on telemedicine for the physician services. So the model of care being studied in this instance is that patients would come to a clinic location close to where they lived, and at that clinic there would be nurses and non-nursing support staff who would supervise the administration and dispensing of medication and the collection of urine samples. And the physician would dial into the clinic using secure video conference on the Ontario Telemedicine Network in order to assess the patient and write the prescription. For the in-person care, everything was the same except the physician was there in the clinic as well as the nursing staff and other staff. And so really the only difference between the two groups is how often the physician was available by telemedicine. For the patients whose physician was available 75% or more of the time by telemedicine, you see the solid gray line. For those where the physician visits were between 25 and 75% by telemedicine, it's the dotted line. And the solid black line are patients who receive care with the physician in person more than 75% of the time. And as you'll see here, that treatment retention and the other outcome measures that we looked at, including other opiate use and so forth, were basically equivalent, or if anything, the telemedicine group did better than the people seeing their doctor in person. As to why the telemedicine group may be doing better than those in person, we don't have hard evidence to really clarify that question. Like much good research, this raises new questions to be examined. But what the important point in the context of thinking about virtual care is that in this context, virtual care is as effective or more effective than having the physician services done in person. So that is the situation prior to the pandemic, when about 50% of the telemedicine services in the province were being used to deliver opiate agonist treatment. And so it's an important consideration for thinking about virtual care overall in the province and how it's evolved since the pandemic. In a little bit later study, we used ICES data to look at patients who received care by telemedicine versus those in person. And you'll see here that when we look at other healthcare outcomes, all-cause mortality, hospitalization related to opioids, emergency room admissions related to opioids, mental health emergency room visits, all of these outcomes for the group in receiving telemedicine were better than the group receiving care in person. So again, regardless of which way we look at the care, opiate agonist treatment delivered by telemedicine is at least as effective as the same treatment delivered in person. We look now at the impact of the pandemic on opiate use disorder and opiate overdose deaths. Early on in the pandemic, it was clear that opioid overdose deaths had started to increase. So this is looking at just the first few weeks of the pandemic. And and see that once the state of emergency was declared, the number of overdose deaths per week started to increase, with the projection of a 50% increase over 2019 if that trend had continued. A little bit further on into the pandemic, the data was evaluated again, and you can see that the average number of deaths per month related to opioid overdoses clearly increased during the pandemic. Not a full 50% increase, but from 197 per month to 292 per month. So a very substantial increase in opioid-related deaths during the first year of the pandemic. And looking again at this data, you can see that prior to and during the pandemic, fentanyl was the opioid particularly leading this cause of death in relation to opioid overdose deaths in Ontario, both before and during the pandemic period. This is data from our own group looking at the prevalence of fentanyl-positive urines in different public health units across Ontario, pulling data from a group of clinics that have clinics in every public health district in the province. And you can see that the darker green areas are areas where there was more urines tested for fentanyl were more likely to be positive. So prior to the pandemic, fentanyl tests were more likely to be positive around the Golden Horseshoe, Hamilton area, and Southern Ontario, Central Ontario especially. But in Northern Ontario, there were very few fentanyl positive urine, with the Sault Ste. Marie area being an exception. After the first 6 months of the pandemic, the number of fentanyl positive urines increased across the whole province, but particularly in Northern Ontario, where we saw a 5 to 6-fold increase in the fentanyl positive urine tests in these clinics over the first 6 months of the pandemic. So the pandemic seems to have shifted the illicit drug market and made fentanyl widely available pretty well across the province. Now, when I say fentanyl, it's important to understand that this is illicitly produced fentanyl that may be fentanyl or any number of analogs of fentanyl, including carfentanil, which is much more potent than fentanyl, acetylfentanyl, acetyl carfentanil, and so forth. The illicit opiate market in Ontario at this time is really producing a mixture of various very toxic and potentially lethal compounds, with people using illicit drugs having really no idea what's in the drugs that they're buying and using, and a big range of effect with the same amount of drugs used, putting them at very high risk of overdose death at this time. So what happened to the provision of virtual care during the pandemic in this opiate agonist treatment context? In the specialized clinics that I described, the physician visits moved to completely by telemedicine, but the clinics stayed open. The staff continued to be in the clinic for dosing and urine testing and social support. There were plexiglass barriers and masks and limits on the number of people in the waiting room and so forth in order to maintain social distancing. But using those physical and social distancing measures, there were no outbreaks identified within any of the clinics in this network. That's about 70 clinics across all of Ontario. And so the measures taken to prevent infection spread seem to have been effective, while allowing the clinics to stay open and provide care, with the only difference being that all of the physician visits shifted to telemedicine instead of about 50% telemedicine and 50% in person. Other providers of opiate agonist treatment in the province, including hospital-based clinics and others, took a different position. Many of those hospital-based clinics were closed, with the nursing staff and others being redeployed to the emergency room. Physicians started to increase the number of take-home doses that patients could have, and thus reduce the amount of monitoring, reduced urine testing, virtual care, by phone in the patient's home became much more common. And so the concept for you to remember out of this is that virtual care is a heterogeneous concept. And in particular, after March of 2020 in Ontario, virtual care became a very mixed bag of different ways for physicians and patients to connect with each other, which may have impacted the outcomes of care and health system utilization in a number of different ways. So more broadly now about virtual care, it's the case, as I described, for opioid agonist treatment, but for virtual care in general in the province. Prior to the pandemic, virtual care in Ontario was only done by the Ontario Telemedicine Network. This means that there had to be specific hardware and software used. The physicians had to go through a particular approval process in order to offer care, and there were specific fee codes used to reimburse physician care. In March of 2020, the province made an important change. They opened up options for virtual care so that it could be done by any communication system or platform, by phone, by video conference using Skype or Zoom or any range of video conference options. There was a shift in billing so that new billing codes were introduced and the OTN specific fees were removed. And there was a really rapid shift from in-person to virtual care across almost all medical specialties. There have been a few publications that have looked at this. So this is from Dr. Bhatia and group in CMAJ early in 2022, showing that across all geographies, socioeconomic groups and physician specialties and patient ages, the use of virtual care really exploded. And you'll see in these graphs that they're using a log scale. So you're seeing the number of visits by virtual care increase by 100-fold here, or almost 2 full log units, while the total ambulatory care visits initially stayed constant. So really, this was a period when physicians were replacing almost all in-person visits with virtual care. The percentage of visits being done by virtual care went from just under 2% to 70% of visits, and 7% of physicians using virtual care went to 85% of physicians using virtual care in the first few months of the pandemic. So it was really a rapid shift to virtual care across almost all aspects of physician services in Ontario. This shift to virtual care had a particular impact on certain patient groups. Patients in urban areas saw more of a shift to virtual care than those in rural areas where perhaps virtual care was already more well established. Older patients had a larger shift to virtual care than younger patients. And patients with more frequent visits had a larger shift to virtual care. And Welk and group calculated the impact on the environment of this. So one of the clear benefits of shift to virtual care is a reduction in travel. They estimate that 3 billion kilometers of travel was avoided by physicians and patients, mostly patients, and 658 million kilograms of CO2 emissions prevented during the first year and a half of the pandemic, or from March 2020 to December 2021. This represents visits from over 10 million patients and almost 64 million physician visits done by virtual care. If we look at the entire population of Ontario and physician visits, you can see that prior to the pandemic, almost all of the care was done by physicians in person, although virtual care was slowly growing across the province. And then suddenly there was a turnaround to virtual care taking over. By March of 2021, in-person visits had started to increase as a proportion of all visits, but as a number of visits per 1,000 adults. But the use of virtual care continued to increase as well. And so by March 2021, with this new reality of virtual care being adopted by almost all physicians, the total number of physician visits had actually increased by 56%. Now, some of this is an increase in visits after a period in the early part of the pandemic with reduced number of total visits. And so there was some catch up. But it seems by March of 2021 that there was an overall larger number of physician visits being done while still relying on virtual care for the majority of those visits. In terms of the platform used for virtual care, prior to the pandemic, it was entirely OTN. And that was because of the restrictions in place in terms of physician billing and the ability to use different platforms. Once the requirement to use OTN was taken away, the use of OTN dramatically decreased, so that the rapid expansion in virtual care was almost all happening with a move to phone visits or other video conferencing systems. Some of those video conferencing systems were better integrated into the electronic medical record for scheduling and billing than OTN could be. And so there are some considerations for thinking about the future of virtual care in terms of which systems ought to be used, how they ought to integrate into the EMR and scheduling and billing, and also considerations about security. OTN was always designed to be particularly secure with a high emphasis on ensuring that it was the patient and the physician interacting and that there weren't other people around the patient at the time of the interaction. When the requirement to use OTN was removed, there were guidelines put out about how to deal with your patient when you were talking to them on the phone or by some other video conference platform to ensure that you could maintain their confidentiality and you had their consent to use these other systems to communicate with them. But it's a consideration for expanding virtual care. To what extent do you build restrictions into the platform itself to ensure patient confidentiality and consent? And to what extent do you rely simply on the physician and patient discussing it to make sure those considerations are addressed? So we've looked at opiate agonist treatment, patients receiving that. We've looked at the entire general population. If we look at some specific populations within the general population, looking here at patients with chronic conditions, so things like diabetes, hypertension, chronic mental health conditions. You can see that when you track those visits by week, there's some seasonality and fluctuation, and particular drops in number of visits in early January every year. But overall, a fairly flat trend line for the couple of years before the pandemic, with almost all of the care being done in person. Then in March 2020, a rapid shift to virtual care with the total number of visits, the pink line here dropping slightly, but green virtual care line rising dramatically. And then as we work our way through the first year of the pandemic, you can see that the total number of visits quickly returned to close to its baseline level. You still had that seasonal drop in January, first week of January. But what this shows is that there was a decrease in total number of visits initially, but it stabilized back to the baseline level, with virtual care accounting for just around 50% of care once physicians had implemented virtual care and physicians and patients became comfortable with those options. So it's quite likely that as long as the systems are in place to support it, there will continue to be a mix of in-person and virtual care for these patients. And what impact did that have on the outcomes for these patients? Well, if we look at hospitalizations and differentiate patients with low volume of physician visits and those with a high volume of physician visits, we can see that prior to the pandemic, those who were seeing their physicians more often had an increasing rate of hospitalization. And these are patients who are probably more severely affected by their chronic condition, whether it's diabetes, COPD, heart failure, mental health, so forth, that immediately upon the declaration of the pandemic, rates of hospitalizations fell for all these conditions. That was a period where everybody was uncertain about what was happening. The hospitals were overwhelmed with the concept of and the number of people coming with COVID-19. Patients with chronic conditions were particularly worried about going to the hospital during that time and the risk of being infected. But over the subsequent months, the number of hospitalizations recovered. And it continued to be the case that the people with higher rates of physician visits were more likely to be hospitalized. But there's no dramatic increase in the number of hospitalizations for any of these chronic conditions, despite receiving care by virtual care most of the time, or up to 50% of the time towards the end of this period. And so we can assume from this that, or surmise from this, that the care by virtual care was no more likely to lead to hospitalization than the care delivered in person for these patients with chronic health conditions. Another area that's been looked at specifically are virtual walk-in clinics, and there's been a lot of coverage of this in the media. It's been an issue raised during the OMA Physician Services Agreement negotiations. But this group looked at patients attending 13 specific virtual walk-in clinics that they selected for comparison to the entire rest of the population of Ontario who received some primary care visits by virtual care. When they compared those patient groups, the patients who used virtual walk-in clinics had less comorbidity, they were younger, and they had fewer previous healthcare visits. They were more likely, despite being younger and less sick, to have repeat virtual visits if they went to a virtual walk-in clinic than if they saw another primary care physician by virtual care. And they were twice as likely to have an emergency room visit within 30 days. So this has been used to make the argument that virtual walk-in clinics are less effective and a lower quality of care than the care delivered by comprehensive primary care physicians or regular primary care physicians, even if those primary care physicians are using virtual care to deliver the care. And so it's important, I think, not to generalize from this data to suggest that all care by virtual care is less effective or more likely to lead to emergency room visits. But there are certain contexts where it seems virtual care is less effective and more likely to drive increased healthcare costs through increased repeat visits and increased use of the emergency room. And so the story around virtual care is not all supportive of virtual care being equally effective to regular care. And I think we need to think about those consequences as we consider increasing the number of ways that virtual care can be rolled out into the healthcare system. I'll close with a few examples of innovation in virtual care that have been done in Northern Ontario that unfortunately have not yet been published in peer-reviewed literature. The rest of my slides have the references to the peer-reviewed literature on them, and we can make the slides of the original papers available to you. Health Science North established a virtual emergency room during the pandemic. The concept here is that patients who were considering going to the emergency room, instead of going and seeing the triage nurse in person, could call and have a virtual assessment booked with one of the ER docs. The ER doc would then either phone or video conference to the person at home and do an assessment and evaluate whether or not they needed to come to the emerge and develop a plan for their care. With the results being that 50% of these patients were able to be dealt with through virtual care and avoid coming to the emergency room completely. Another service at HSN, which existed prior to the pandemic and became more important during the pandemic, was a virtual critical care service. Now, this is where the critical care physician is based at the Academic Health Science Center, but the patients are admitted to one of 26 other hospitals across Northeastern Ontario. And those hospitals don't have critical care physicians. And normally, patients who require critical care would be transported by helicopter to Sudbury or another center to be admitted to the ICU or CCU. Through having OTN terminal brought to the bedside, the critical care physicians could video conference in, assess the patient, discuss the care with the nursing team and the primary care physicians in those other hospitals, and try and develop a plan of care to avoid transportation and continue to provide critical care to the patients in their remote sites. And this has been very successful and well appreciated by the physicians and patients. Who patients get care closer to home, they're more able to be supported by their families, and the physicians in the remote sites are able to deliver more complicated care effectively to patients in need of that care. Another example developed during the pandemic was the virtual sexual assault care in Northwestern Ontario. The sexual assault team is based at the Academic Health Science Centre in Thunder Bay. And prior to the pandemic, patients who had presented after a sexual assault would be transported, usually by helicopter, to Thunder Bay, where they would be assessed, appropriate samples collected, and so forth. During the pandemic, in order to avoid those transports, the team in Thunder Bay developed a virtual sexual assault care where the sexual assault team would connect by video conference with the healthcare team in those other sites. They would help ensure that the appropriate samples were collected, that the supports were given, that the kind of care that's necessary for supporting victims of sexual assault, mostly, unfortunately, women, was able to be delivered closer to their home with less requirement for transport and less trauma for the patients related to the care itself. So, in summary, I hope I've illustrated to you that virtual care is a real heterogeneous basket of services and platforms that most of the time the data shows patient outcomes can be equivalent to in-person care with benefits for the patients, the providers, the healthcare system, and the environment. But there are potential concerns in some situations for quality of care, for cost and appropriateness of the virtual care. I think there continues to be room for innovation in terms of remote sensing, integration with EMR, and other novel healthcare contexts in which virtual care can be integrated. Thank you for your time, and I'd be happy to answer questions. I'd also like to acknowledge my own research team and the funders who've helped support the research on opiate use disorder, which I described. Thank you.
Thanks, everyone. And we do have Dr. Marsh on the line to answer any questions. So please do let me know that if you have any questions. Should be up in just one moment. Hello, sir. Thank you for joining us, and thanks for an excellent talk.
Oh, you're welcome. I'm glad to be here. I'm glad it worked out.
Perfect. So please prepare your questions. Raise your hand if you have something, and I'll come over with the mic. I'm happy to get things started off, though. I think it was a great summary that you just presented. Yes, there are so many different facets of virtual care. And with the perspective that you have now, you gave us some statistics saying that, there was 2% virtual care visits that bumped up to 70%, and that 85% of practitioners were able to take on virtual care delivery. What would you see as the important statistics for us to capture going forward so that we can continue to make improvements in this type of delivery? What is important for us to look at?
I think it's most important to try and capture data that reflects actual quality of care and patient outcome, especially patient outcome from the patient's perspective. I showed you some data in terms of rates of admissions and hospitalizations and so forth, which is an indirect measure of quality of care. I think, generally speaking, in our healthcare, we tend to measure volumes of activity rather than the actual impact of those activities. And so figuring out ways to look at the real patient outcomes from their perspectives and in terms of health economics, cost effectiveness, and reduced quality adjusted life years and so forth I think would be really useful in determining what is the most cost-effective way forward.
All right, thank you very much. Yeah, it's definitely a different, difficult question to tackle is how we can actually get those impact measurements. So I hope that some of the students in the audience will be looking to look at that. I wonder if there's any other questions from the audience? Great, it seems like we have something online, and I'll come to you next.
Thanks for a great talk. I have an online question here, and just following up on your last answer. Is there a plan for formally developing KPIs and evaluating the quality of virtual care in Canada?
To be honest, I don't think the Canadian healthcare system develops a national strategy for anything. There certainly are people in specific specialties or certain areas of care that are trying to look at patient-oriented outcomes and to develop KPIs. Much of the KPI work has been done from a hospital administration and funding perspective, and I think tends to focus more on volumes of activity than on actual impact of the activity. But I would certainly look for more research teams to look into how we can measure out health outcomes more effectively.
Wonderful, and we have another question from the audience.
Thank you so much for the information. So recently and during the pandemic as well, I've seen a lot of rise in virtual care being delivered internationally as a result of kind of avoiding healthcare tourism. A lot of my friends and I go back home to get care from specialists, do surgeries, etc. Have you seen anything in Canada officially being done, to systematically implement that or leverage international healthcare virtually to meet our demands currently?
Yeah, that's an excellent question. And it's very controversial. I don't see a lot of Canadian physicians providing care to patients internationally. There's some small situations where I believe that's happening. What is happening is, as you say, Canadian citizens accessing care from other countries, which brings risks for the patient, which are not often appreciated in terms of what recourse they may have if things don't go well. They would then be looking at the difficulty in suing for malpractice in another jurisdiction where they don't live, difficulty trying to get insurance coverage for dealing with the unexpected negative complications of the procedures that they've had internationally when they may have to come to Canada to deal with the consequences of something that hasn't gone well. Nevertheless, I think you're right that there's more and more issues about Canadians accessing care from physicians outside the country. There are, in the medical education world, some growing discussion around international standards for medical education, for physician degrees, for accreditation of physician training, and efforts to try and ease the mobility of physicians from country to country, and also some very early discussions about broadening physician licensure, which would create an easier way to hold somebody accountable if they, for example, there was a case in, I think CBC, one of the local media, or Global Mail, covered relatively recently of a physician in Canada who had lost his license in Canada and then is now actively practicing in Mexico, and Canadians fly down and see him there, even though he had pretty significant concerns about his quality of care, enough that he lost his license to practice in Canada. So, but there's no way for the Canadian regulators to hold him accountable for practicing without a medical license in Mexico and treating Canadians. So I think you understand what I'm getting at, that there's issues around regulations, licensing, quality of care, and legal recourse when things don't go well.
Absolutely. So thank you, Dr. Marsh. That is all the time that we have today. So we really appreciate you calling in and answering our questions. And I hope you enjoy the rest of your evening. Thanks again.
Well, thank you. And I'm glad that the emergency generators stayed on. We're on emergency power here right now, and that the technology allowed us to connect. I hope you enjoy the rest of the conference. And I look forward to hearing more of what's talked about while you're there.
Fabulous. Thanks again. All right. All right, wonderful. We are going to take a quick 5-minute break before the panel session begins. So our next group of speakers up are going to discuss assistive technology in the real world, all live in person with us. So I welcome you to stretch your legs, grab some refreshments over at the side of the room, and we'll get started in about 5 minutes. I think it's time that we get started just to stay on our schedule approximately. So thanks everyone. I hope you enjoyed the keynote address by Dr. Marsh. We are going to start our first panel session of the conference now, entitled Assistive Technology in the Real World. So I'll invite the panel up to the stage to take your seats. The moderator for today is Professor Warren Dodd from the School of Public Health Science at the University of Waterloo, and he has the pleasure of introducing the rest of the panel to you.
Thank you so much, Carly, and thank you everyone for coming. It's great to see everyone. So it's my pleasure to be the moderator for this panel. So on the panel today, we have Dr. Scott Adams, who's an attending radiologist with the Saskatchewan Health Authority. We also have Professor Alfred who is a professor in the Department of Electrical and Computer Engineering and an NSERC Stacy Fellow here at the University of Waterloo. And then we have Kerstin Dautenhahn, who is also a professor in the Department of Electrical and Computer Engineering and the 150 Research Chair, Canada 150 Research Chair in Intelligent Robotics here at the University of Waterloo. So please join me in welcoming the panelists. So the way things are going to work today is each panelist is going to give a presentation on their work, and then we're going to have a conversation kind of bringing together some themes around technology and accessible care and what that looks like in connecting what's happening within universities and within research and connecting that within practice as well. So first up, we have Dr. Scott Adams.
Well, thank you for that very kind introduction, Warren. It's great to be with all of you today. I really applaud the organizers of this conference for choosing a theme that's so relevant to us today, using technology for accessible care. I think we've seen tremendous advances during the COVID-19 pandemic on virtual care, ways to increase access to care. But I think there's tremendous room for innovation because we continue to see gaps, we continue to see disparities in many of our communities. Would we be able to advance to the next slide here? Doesn't look excellent. Yeah, so really, this presentation will be about using technology for accessible care and specifically describing our work on improving access to ultrasound imaging using technology, telerobotic technology in Saskatchewan. We know that access to healthcare services is an important determinant of health. I'm from Saskatchewan. It's a major tertiary care center for the province. But when we think of the many other communities across our province, I'll use Stony Rapids as an example. The closest location for ultrasound services, which is one of the most basic imaging modalities, high utility imaging modality, the closest ultrasound center is 673 kilometers away from this community. And when we discuss tertiary care services, subspecialized services, the closest center is Saskatoon, which is 795 kilometers away. So just the geographic barriers for many of these communities are significant. And I think when we begin to reflect on what are the potential solutions to bridge these gaps in care, the first step really is understanding what are these barriers. And for this study here, we specifically focused on ultrasound imaging and began to explore what are the perceptions of access and factors which impact access to ultrasound imaging among northern remote community members in Saskatchewan. And we took a qualitative approach, and 5 themes are identified from our work here. One, geographic isolation. And for accessing healthcare services such as ultrasound imaging, this required flight. And of course, this comes with challenges. When we spoke with individuals here, there was a recent plane crash near their community. So there was a fear of travel. What if they're next? In accessing something as simple as healthcare services. So fear of flying, isolation from family. Many times when patients needed to travel for an ultrasound exam, funding wasn't available to bring their partner or other family members. They were going to a larger city by themselves, to a foreign place, to an unfamiliar place. For residents in urban centers, an ultrasound exam might take 1 or 2 hours. But for residents in some of these northern remote communities, an ultrasound exam takes 1 or 2 or even 3 days with the travel required and coordination of air travel. And competing family and work responsibilities often get in the way. When one has a family of 1 or more children at home, traveling is a significant challenge, particularly when childcare may not readily be available. But despite these challenges, individuals viewed ultrasound as a tool towards securing health. They placed a significant importance on ultrasound services near one's home community. And we also sought to determine whether some of these barriers to access to ultrasound imaging were also reflected in differences in utilization rates. So we undertook a population-based study, including essentially all individuals in a province, so just over 1 million individuals, to assess the association between socio-demographic and geographic factors and obstetrical ultrasound utilization. And when we looked specifically at second trimester obstetrical ultrasound, so this is an exam that's recommended that all individuals have in their second trimester of pregnancy. We saw individuals living in a rural area 30% less likely to have an ultrasound exam compared to those living in an urban area. And those living in the most remote areas, 65% less likely than those living in urban centers. Status First Nations individuals, 50% less likely. Those living in highest income neighborhoods, 86% more likely to have an ultrasound exam than those living in low income neighborhoods. So we see some of these barriers also reflected in differences in utilization rates. People are foregoing ultrasound exams that generally as a medical community would be a recommended exam. And we also conducted a study looking at utilization rates of non-obstetrical ultrasound exams, so abdominal, pelvic, or renal exams. And we saw many of these same factors in this study as well. Rural residents, geographic remoteness, Status First Nations, individuals less likely to have lower ultrasound utilization rates. So really, I think as a medical community, as a health research community, new solutions are urgently required to bridge these gaps, both in access and utilization of ultrasound imaging. And in Saskatchewan, we've explored telerobotic technology as a way to remotely perform ultrasound exams. So using this technology, a sonographer in an urban center, such as Saskatchewan, can remotely manipulate a mock probe. And all movements of that mock probe, rotation, rocking, tilting, can be directly replicated at the patient's site, whether it's hundreds or even thousands of kilometers away. And sonographers can control ultrasound settings such as gain and depth and communicate with the patient using a video conferencing system. And we conducted a clinical trial to validate this technology to perform obstetrical ultrasound imaging. And we found excellent interclass correlations between conventional and telerobotic ultrasound, greater than 0.99. All findings identified on conventional exams are also identified on telerobotic exams. We did find limitations in the system to identify all fetal anatomic structures required as part of a detailed fetal anatomic survey. So as a radiology group, we decided that 80% visualization isn't sufficient, and we decided not to pursue second semester ultrasound exams using this technology, but we do find it's adequate for first semester, for third semester ultrasound exams. So these are exams that do have sufficient diagnostic adequacy to conduct these types of exams, just not second semester exams. So with this clinical trial behind us, we've now launched telerobotic ultrasound clinics in 3 northern communities in Saskatchewan, in Stony Rapids, The Loss, in Pelican Narrows. And since launching these studies, as part of these studies, we've surveyed participants. We found that participants appreciate having ultrasound available closer to home, eliminating or reducing some of the barriers that were identified in our previous studies, eliminating the need to travel, minimizing travel costs, providing increased convenience. And this also has the potential to decrease wait times, to reduce time to diagnosis, not having to wait for an itinerant sonographer to travel to the community on a monthly or bi-monthly basis, not having to travel to another center for some of our more acute care needs. We also were able to utilize this technology during the COVID-19 pandemic. We rapidly launched a clinic in La Losse, and during the COVID-19 outbreak, we were able to reduce the need for an itinerant sonographer to travel during the COVID-19 pandemic, minimizing spread of infection during the pandemic. So a lot of our work has been focused specifically on ultrasound imaging, and really this is just one of the imaging modalities available to us as radiologists. We really must expand our work to include CT, to MRI, to PET-CT, and even look beyond medical imaging to look at the other diagnostics, clinical chemistry, surgical pathology, some of the electrophysiology tests. And really, a focus on diagnostics likely is insufficient because if we do find pathology, oftentimes those patients will require referral to other specialists. So thinking about how we can not only improve access to diagnostics, but improve access to treatment in general for rural and remote communities. And really, we must rethink our entire model of providing acute care, thinking about providing not only care within hospitals, but hospitals at home. And this is where it really gets exciting, because not only are we providing effective solutions for our rural and remote communities, which may not even have a hospital in the community, but thinking for the entire Canadian population, entire North American and world population as a whole. How can we better provide services closer to home or even in patients' home? And I think that's where it gets really exciting from a health research perspective, from a clinical perspective, as well as from a commercialization perspective. So in conclusion, there are significant challenges in providing medical imaging services in Canada's rural and remote communities. New solutions are urgently needed to address the gaps in health services, particularly ultrasound imaging, which is one of the core imaging modalities for northern and remote communities. I'd like to acknowledge the many individuals who have been part of this work, our funding partners, and I'll turn it over to Warren as we continue our panel.
Thanks so much. Yeah, that was really interesting. I think sets up the need for innovative solutions. So up next, we have Professor Alfred Yu, who's going to continue the conversation.
Well, I just wanted to build on what Dr. Adams have been talking about. So being the ultrasound geek on campus here, I perhaps would take a deeper dive into ultrasound and really talk about whether or not it's a suitable tool for point-of-care applications. We've seen Dr. Adams trying to apply existing clinical ultrasound technologies for use in remote communities and virtual care. Is it suitable right now? Okay, in terms of like being able to address all the needs. Okay, or what are the other what are the challenges that that remains to be addressed? So that's something that I would hope to kind of talk about for the next few minutes. So what can we do right now with ultrasound? Okay, so if you take a look at the current technology, like we actually have gone through a pretty intensive phase of engineering where nowadays there are these portable scanners. In fact, we do have handheld wireless probes available, and you can actually connect it to a smartphone, right? And also be connected to a cloud, which is all good, okay, from a telemedicine standpoint. And from an application standpoint, we have been seeing that ultrasound has been widely used to image organs, anatomical structures. In O&G, of course, it's a huge application. It accounts for 25% of the ultrasound market. So there has been quite a bit of use and applicability, like in clinical application, in various clinical areas. So ultrasound is actually pretty good these days in terms of being able to do something. But then at the same time, ultrasound cannot do quite a number of things. let's just take a look at this particular example here. If we are trying to use ultrasound to track dynamic events, the current technology just isn't there yet. We can't really track like complex blood flow, as in this particular example here, where we are showing the color Doppler imaging cine loop that is being acquired from a clinical scanner for the case of a carotid bifurcation. So as we actually have flow branching out at that bifurcation point there, you actually can see that the flow being rendered within the cine loop. We can't really see much, right? We see flashing once every so often. That's due to the systolic flow, okay? We see the red color, the blue color, kind of like appearing in the image, but we can't really like see much in terms of what is happening from a flow trajectory. Like what's the flow trajectory like, and like what the flow directions like. We actually need quite a bit of imagination in order to make this to be something that we can interpret. And the other issue that we are facing with current technology is, even though the frame rate is in real time, we're talking about 17 frames per second here, so it's just kind of like video range frame rate, same as what you would see on a TV. But then, like if we wish to track complex flow, it is actually very hard for us to rely on 17 frames per second frame rate to resolve all the details within the pulse cycle. So the current technologies have this issue where if you want to use it for dynamic event tracking and visualization, there's actually quite a number of challenges that need to be overcome. So what we are trying to work on is to try to take a very deep dive into the imaging physics behind ultrasound, okay? Going from first principles. How can we design high frame rate imaging solutions that enable us to look at blood flow in a more consistent and intuitive manner? So we have been working on various things like the vector projectile imaging technique, where we're able to observe what is really happening, okay, in terms of flow trajectory. So as you can see in that same bifurcation example, we're able to consistently visualize the flow jet, and there's a bit of flow circulation near the carotid bulb. In order for us to try to take this forward, we try to also build various engineering solutions, okay? These algorithms that we are developing, they are quite computationally intensive. Well, thanks to GPU, we actually are able to come up with various real-time implementations. And we are also trying to come up with open platform systems that enable us to try to get these to be implemented and to allow us to do various clinical studies. And just kind of like as part of the fun in the lab, what we are also working on right now is trying to design these like vascular models where we actually can use, okay, to test the efficacy of our algorithms and to fine-tune their performance. And so with all these engineering endeavors, we have been able to try to get our solutions being applied towards use in clinical practice. And we've been also doing quite a bit of technology transfer with the ultrasound industry. But after doing all these for the past decade, we are still scratching the surface. There's actually a lot that remains to be done. Okay? So right now, for our open platform ultrasound system development, we actually are still working with a huge card-based system. How can we actually try to miniaturize this even further? This is a huge engineering challenge that remains to be addressed. And if we are able to do this, this will be great because we want ultrasound to be ultimately used for point-of-care diagnostic applications, right? And another huge challenge, and I think that's something in which we can discuss a little bit further at today's panel, is how can we efficiently try to translate our innovations towards use in various application areas and various application settings. Like we are mainly looking at hospital care for the time being, but can we also try to like bring this forward, okay, for use in remote communities? Now this is something very interesting. If we can do this, this will definitely broaden the impact of all these emerging technologies that myself and other ultrasound researchers have been developing. And with that in mind, that brings me to the end of my little presentation here. I'll pass it over to Kerstin.
So my area of research is a little bit different from what the previous speakers have discussed. It's still about assistive technology, but I'm particularly passionate about robots, in particular social robots. So these are robots that can interact with people in human-centric terms, as we call it. What does it mean? It means these are robots that can behave socially, that use verbal as well as non-verbal behavior in order to interact with people, communicate with people, assist people, and can also, for example, collaboratively solve certain tasks. So I moved here to Canada, to Waterloo 5 years ago, where I had the opportunity to build up the Social and Intelligent Research Robotics Lab, but I've actually been working in this field for 25 years now. And so the field has really dramatically developed. When I was a student, there were no commercially available robots around. Here you see some of our robot zoo that we have here in Waterloo in the SIRRL lab. 20 years ago, people didn't have such an opportunity. So the field has dramatically advanced, but I like to point out some issues. But before I go to some of the challenges, I want to show some possible applications of social robots. And these are, in fact, also applications that I'm studying with my wonderful research team in the SIRRL lab. So I hope I can start by just pressing again. OK, yeah. So what you have seen here are different applications. So in some of our projects, we work with children. This could be therapy. This could be education. In some, we work with adults, like those sitting here. It could be about relaxation. It could be about health coaches, for example, robots that are encouraging and coaching exercise, making sure people don't over-exercise or under-exercise. It could be in the sense of mental well-being. It could be robots used to practice relaxation techniques, mindfulness, for example. Or it could be providing assistance for older adults to keep them living independently for longer in their homes, for example. But you also saw an example of assistance for a robot co-worker, which could be in an industry context. Of course, there are many, many challenges. This is a very interdisciplinary research. You need not just very talented engineers. You need to work and collaborate with therapists, with teachers, with psychologists, with anyone who can possibly help you and give you insight in this application domain. And so I have many, many collaborators here in Waterloo, but also elsewhere. So this could be about assistance, but it could also be about diagnosis and applications about virtual care, which I'm not going to talk much about. We heard a keynote talk about it earlier today. So in this work, in this very human-centered approach, you need to very, very closely work with the stakeholders, not just the users, let's say the children you want to help, as a coach or as a therapist, but also with other stakeholders like the teachers, the therapists, the parents. You need to also get buy-in from them, and you need to co-design with them. So not just for them, which is the classical approach in many robotics and generally engineering projects. You need to design with people, to make sure that, you know, that you adapt and you personalize and individualize what you're doing, not just with respect to individuals, but also to the particular application area. So you need to go through this whole co-design process iteratively. You might start with a focus group. You have then initial design ideas, initial prototyping, initial testing. Then you might go back to the brainstorming, and. It might go on in several loops, because you need to make sure at each stage that you're doing the right thing and you're doing the thing right. So you need to also think about issues such as usability, user experience, acceptability, and what is the added value of this technology. Because after all, we do not want to replace teachers or therapists or other educators. We want to add, we want to provide these robots as tools in the hands of professionals. But often there are barriers. It might be the cost of the technology. Who will own the technology? Who will have control over the technology? How can it be made accessible? Who will pay for access to the technology? Who will maintain and upgrade the technology, and at what cost? Who will benefit most from the technology? This is actually not specific to social robots. I think it probably applies to all kinds of technology, advanced technology in particular. So what are the issues then to put these robots out in society? Commercialization is important, and I showed you the zoo, the different robotic platforms that we have for different application areas. They are commercially available robots. They're being sold by companies, and there are many successful robot companies. But also sometimes those companies fail, and there has been a few years ago some stories in the news with, this is a very popular robot, the Pepper robot. It was discontinued by SoftBanks, but then actually sometimes they go back. They might go back to the original smaller company that was bought by SoftBanks. And you see many examples actually of those. But what this means is that sometimes the business model and the expectation that people have need to be adjusted. So what could be the reason, for example, for one of these failures? It could be that researchers as well as companies sometimes overpromise and underdeliver. And I like to point here to something that I see not just in robotics, in all science basically. Sometimes people prepare videos, demo videos, concept videos that show how the problem has been solved. And then you get the product, you investigate it, and you realize, no, it hasn't been solved. It can do something, but it doesn't meet the expectations. So there really is the need, and I tell this to all of my researchers and graduate students repeatedly, we need to be honest when we are writing up, when we are presenting this work. We need to be clear what the robot can do and what it cannot do, and how its services might be better than, for example, voice assistants that are now quite prevalent. And many other examples are there too, where people, first one of this Cosmo robot, a very popular, more play-like assistive robot, was discontinued at some point, but was then bought. The IP was bought by another company, and hey, now you can buy Cosmo 2.0. So there are really these very interesting discussions out there that are identifying barriers and what we can do as researchers to also have more transparency about the technology, what it can do, what it cannot do. So it's not enough just to have a fancy one-off demo that took you 5 months to prepare until the system actually works. But no, you need to create these systems that are reliable and that could be put in the field. And field studies are in fact an important aspect of our work, and just to be honest and not to rely on these fancy, this is Sophia, it's almost human, and it was granted citizenship in a country. So we have solved the problem how to build humanoid robots. We haven't solved anything. You also need to look at acceptance, not just of the actual users, but also the organization, the societal context. And there are many, many research challenges involved, not just technological, but also methodological and also societal changes, because there is a danger with some of those fancy pieces of technology that they might just end up being a luxury item or a very expensive item that only very few selected people can afford. Thank you. I guess it's back to you.
Yeah, so thank you very much, everyone. Those are really thought-provoking presentations, and I think a great foundation for a bit more of a conversation on these themes, especially in terms of trying to bridge that the design and creation of some of these technologies with application and healthcare practice. So in terms of a first question to kind of start us off, I really liked raising the issue of co-design and thinking about who are the intended audiences for these technologies at the design phase. And so I'm just interested in people's perspectives on how context, appropriateness, culture, intended audiences can be and should be considered in the design of new health technologies, especially when we're thinking about populations that have been underserved or have historical experiences of marginalization. Yeah, I don't know if anyone wants to start the conversation or take that on.
Yeah. Well, I can do an initial stab at that question. It's a big question, and certainly a challenging and an important question for us to get it right as both a healthcare system and as a health research community. Because we do see communities being marginalized. That's why we do see some of these barriers. That's why we do see some of these disparities in health outcomes and even something as simple as utilization rates of really a basic imaging modality. And in Saskatchewan, a lot of our work has focused and partnered with Indigenous communities, which do have specific needs, specific expectations, both when doing research, but as well as when clinical services are provided to these communities. And really, it's that co-developed, that partnership, these activities being Indigenous-led are certainly critical. And it's only with work that's really Indigenous-led that we'll be able to implement solutions that truly do meet the needs of some of the communities we're working with. And really this co-development process that you mentioned, that's so critical. And embedding our users, embedding our patients into the development teams, bringing those same users together to then focus on the clinical implementation aspect, focusing on bringing those individuals together when we think about commercialization, and involving those same communities in that commercialization effort as a potential economic driver for many of the communities we're working with. Certainly could be beneficial, but really it comes down to having a key understanding of those needs, ensuring that our communities are leading that work, and right from the process of co-development all the way to commercialization.
Yeah, I don't know, Kerstin, when you brought up co-design, if there's an example from your work of where that's been done really well or really successfully or effectively, if there's an example from one of your projects.
Yeah, I mean, I'm normally, people who know me know I'm quite modest, but actually, yes, we had a recent success, I'm proud to say. We had, during the pandemic, we had a co-design project where we carried out 2 studies in collaboration with the Disabilities, Learning Disability Society, LDS, in Vancouver, in British Columbia. They, through fundraising, which is another important point, where does the money for the robots come from? They did fundraising. They were able to buy a robot, a specific robot, where we have the same robot in our lab, very suitable for children. And they were also able then to hire a technician on their side. But we here in Waterloo, we supported them. And the co-design was about, we did not want to change anything on how the instructors at LDS do their instruction. How they do it, the curriculum, how they interact with the children, we did not want to change that. But we developed the robot as a tool. So that, for example, when the child was distracted, which happens quite often for children with learning disabilities. They might get frustrated if they have to do math exercises and they know they are not very good at it because people at school tell them all the time about that, so they might get frustrated. So what instructors normally do is redirection strategies, to sing a song with them, to do stretching exercises, to do breathing exercises, to play games. And here we had the robot having that role, to relax the child, to get the child to focus on the task again, and to praise the child, to give positive feedback. And also then during the instruction and afterwards in the goodbye phase, again, the robot could be was there to motivate the children, to engage the children, which is actually one of the big different advantages of social robots. A, of course, they can do certain tasks, but B, in particular when it comes to children, most children really love robots. It's a big intrinsic motivating factor for them. And we then asked the instructors and the children about acceptability, what did they think about the robots, and we published some really encouraging results. Of course, there's always the occasional child who maybe doesn't like the robot, but you know, that's. But I would say this was a very intense co-design. We had weekly meetings. It was not us here in Waterloo as the robotics researchers creating the agenda and the research program. We did that collaboratively, also measures. You know, really, basically the whole project was designed together. So that, you know, but of course, this was difficult, it was time consuming. And I know why certain people don't do it because of these reasons, but it was very rewarding afterwards because everyone was on board.
I was wondering if we can kind of like chip in from a perspective where it's more tech-centric, right, in terms of tech development. So let's say for building new ultrasound techniques and tools, of course it's important to cater for the needs of people, right? But then at the same time, I'm not so sure as to how co-design can directly come into play. Because oftentimes our knowledge user are actually the sonographers, not the patients. So I was wondering if I can hear from Dr. Adams, like you have been working on both sides, obviously. Like, how did you overcome this conceptual conflict and like the philosophical challenges that are associated?
Right, yeah. Well, when we do think about telerobotic sonography, the two users, well, I guess even more than the sonographers and patients. Sonographers, patients, an assistant at the patient's site, radiologists. So it really is sort of a network approach when we think about who our customers are when it comes to technology development. I think as a physician, everything needs to be patient-centered. So I think when we think about what are our highest priorities, it's making sure that the patient experience is optimal, that we are getting the right diagnosis for each specific patient. And then all of us on the team, sonographers, radiologists, other healthcare providers, about that one common goal of how do we ensure that we provide that right diagnosis, the right patient care for that right specific person at the right time. But how to get there is certainly the challenge.
Yeah, I was thinking, like, let's say for tech development, right? So if I'm to design an ultrasound system, yes, the ergonomics aspect, for sure we should involve the patients and the sonographers, right? But I'm actually not so sure. Let's say the hardcore electronics would require a lot of involvement from users, right? Like of course we want to miniaturize, that's for sure. But it's too low level of a problem to the end users, I think. Like, so I'm not so sure how co-design can be brought into play in every part of the tech development curve. Maybe if at least from an ultrasound system development point of view, it features more at the end stages where we start to develop user interface and improve the ergonomics of the system. So, I mean, that's my thought. But of course, like, that's oftentimes something that I've been struggling, being a geek. Maybe I'm just too nerdy.
But I think it also speaks to how some of these phases of development kind of blend into each other too. and that might be part of it. I don't know, Kerstin, if you had a response.
Yeah, I just wanted to comment on it. I mean, our robots, they are also programmed. They have algorithms, you know. They have microchips and whatever it is, electronics. I think it is always a matter on to what extent would the user or users, not just the patients, but the sonographers, whoever is using it, would they care about it? And when it comes to the robots, for example, people wouldn't care, did you use Java or Python to program it? No,
exactly.
You know, but they would care, what does the robot do? How does the robot look like? What does the robot do with any data it collects? You know, what if the robot breaks? Is the robot learning from me? Is it sensing information? If yes, what information? Who owns that information? So I would say, you know, you cannot involve users necessarily in
every aspect.
Electronics design, you know, that's, you know. But more into the functionality. I think this is the point. Regardless of what technology, what electronics there is, what does it do? And then it's something you can bring to the users and discuss with them if they have any concerns or input or, you know. But yeah, it is.
We do have kind of like draw a line where like,
at some point
which part is kind of like the behind the curtains development. And which part actually is the user-facing aspect that would like, really need
exactly. When would users care? When would it impact either their behavior or what they think or how they feel or their attitude towards the technology?
So I guess as engineers, we still need to know our stuff, right? In terms of how to get things done. Like, or at least get things done to a point where users start to care.
Yeah, so I guess related to that conversation then, and thinking about the trajectory of, okay, we've designed something, now we want to implement it and perhaps even commercialize it. What are the challenges and opportunities you see in the work that you're doing in terms of thinking about implementation, but also commercialization across different settings, thinking not only, we've talked about rural and remote communities, but also communities of people with different abilities or even urban centers, indigenous communities. What are the both persistent challenges that are really hard to work on, but also where do you see opportunities for movement or change in that space?
With regards to health system implementation, one of the challenges for our health system as a whole are the costs involved, and the cost of providing care to northern remote communities are so much greater than in urban centers. And that's very understandable because of the geographic barriers which are faced. But when we think about the solutions that are required, we really must be thinking about what are those solutions that number one, increase quality, but particularly important from a healthcare perspective, that also lower costs. And really, if a solution doesn't lower costs, we're going to need to see a substantial increase in quality for that system to be adopted. I think the easier win for health systems is going to be adopting and implementing a solution which does decrease costs. And I think surrounding a conversation of virtual care, both earlier this afternoon and as well as today, there are a number of solutions, technological solutions, which have been effective to lower the costs associated with care. And we really must further investigate this aspect, because some technological solutions do have the potential to increase costs, others have the potential to lower costs. And it's finding that specific balance for that specific technology and for that specific clinical indication or use case. That's going to be really critical, that we can see decreased cost. I think another challenge we see with regards to the technology development process, particularly when applied to rural and remote communities, is the market size. The market size must be big enough for a startup or more established company to invest in that development process. And for many of these applications in rural and remote communities, the market is fairly small, and that we're not seeing the level of innovation that we could be to really drive solutions forward. So I think it really does come down to a policy perspective that we might require some government funding to catalyze innovation in high priority areas where where the return on investment might not be as obvious to commercial partners. And then thinking about expanding those use cases, something that might initially be developed for a northern remote community application. How can then that be applied to a broader scale? And that might improve the economics as far as commercialization, but still driving that innovation, developing that innovation for those specific underserved communities, so that we continue to progress and reduce those gaps and reduce those disparities we see.
I can say a lot on this, but I'll try to be brief. I think in terms of commercialization barrier, in line with what Dr. Adams has been saying, the huge challenge is the market, okay? We are talking about a relatively small market and not a very high profit margin in terms of like introducing new tech. So if you are trying to get new technologies commercialized just for the remote communities market, it's actually a tough sell to the industry. So that actually is oftentimes a deal breaker in terms of trying to get industry buy-in from that standpoint. And oftentimes they actually would regard working with remote communities or looking at this from a more global health or like working with developing countries, it's kind of like a bit of a philanthropy type of endeavor rather than trying to truly tap into their market. So I think that's actually the major challenge right now, at least in the ultrasound industry. And like in the end, it's either volume or actually it's volume and the profit margin that you're talking about. Like these are two important considerations on whether or not we have a go or no-go decision in business. So unless we have like some support from the government or there needs to be some sort of social enterprise or social innovation type of like element that comes into play. Otherwise, things won't fly, I think. That's actually the challenge in trying to introduce these new solutions to like remote communities.
Yeah, I mean, I am worrying a lot about the cost of technology, not just robots. It could be maybe, you know, a new smartphone or some other technology for diagnostics and so on. So for example, there are many studies showing that social robots can be used successfully for children on the autism spectrum disorder, for example, or some other populations I have worked with. But who would pay for these systems? Some other, well, I don't think, I would not necessarily expect the government or OHIP to cover those costs. I mean, what I was quite shocked about is that during the pandemic, the access for children on the autism spectrum to support dramatically, well, basically stopped, more or less. And now it's coming back, and now there are waiting lists of several years. And for children, early intervention is really absolutely key. You know, if a child is diagnosed on the autism spectrum, ideally you would want immediately support, immediately, you know, with the hope that it would actually help. It would make a difference to the child's and their family's lives, so that they might maybe even live independently, or at least, you know, it would help them. And so this is the situation, and also that in many parts of the world, people are worried how to have the money to bring food on the table for clothing and medication for their children and themselves. And then I sometimes wonder, you know, okay, so I'm working on social robots, or, you know, and it's maybe similar for some other colleagues who work on other technology. There's this huge discrepancy. You know, we know some technology can help, it can be beneficial, but who would fund it? Yeah. Who would bring it out? Because the healthcare costs are being slashed, and you know, so this is worried. I don't have an answer to that. I don't know, but you also don't seem to have an answer. You're just aware of the.
Yeah, I'm just ranting out my challenges.
Yeah, well,
my frustrations.
Yeah, and I think maybe as a final question, it like what I'm hearing too is there is a need for partnerships, collaborations to perhaps see opportunities for technology to be implemented, or that might be a space where there is an opportunity there. So I'm interested in not just collaboration in general or for the sake of collaboration, but also just enhancing capacity of different partners to collaborate. And so that's between universities and healthcare practice, but also with the communities who might be able to use the technology as well. So I'm just wondering strategies, facilitators to really enhancing that collaborative capacity across partners or potential partners in this space.
Yeah. Well, I can give an initial attempt. I don't know. I don't have the solutions by any means, but really applaud the organizers in bringing together this conference. I think that's one of these facilitators, to bring people in the same room from both a health system perspective, from a technology development perspective, from the patients we serve, and from industry as well. I think so many new ideas can be sparked by bringing people in the right room, and really this is just one example of that. When we think about what are the facilitators and how can, I really like that way you frame it, how can we increase the capacity of individual organizations through these collaborations? And really that comes down to initially a true understanding of the needs, and the needs right now in the communities by those patients. And then it comes down to health systems coming to an understanding of those patient needs. And then technology developers coming to an understanding of both the health system and then those patient needs. And then definitely true collaboration between industry and academia. I think that's strong linkage combined with strong linkage with the healthcare system. That's really where we're going to see innovation, more than just incremental innovation, but transformational innovation. Because when we think about the innovation work that many of our tech companies can do, yes, to a certain extent, we can see a transformational innovation, but oftentimes it's universities that aren't necessarily driven by a profit margin, that can invest the necessary resources, that can apply for some of these grant opportunities and pursue high-risk research. And that high-risk research from a technology development perspective could have significant rewards when eventually translated into patient care.
Yeah, I don't know, Alfred or Kerstin, if you have.
I can say a lot, but this time I'll let Kerstin say something first.
Yeah, I mean, I agree having events supporting networking is quite important. I think one of the advantages of the pandemic, if there's anything like that, is certainly all of us have learned to not just do getting used to virtual care, but also to connect and to network virtually. So previously, if I wanted to, visit someone maybe on the other side of Canada, which I've learned is a long distance away, in BC, for example, then I would have to, drive there or fly or whatever. Now it's much more accepted if you say, oh, if you're interested, maybe we can have an initial conversation over Zoom. And then eventually maybe meet if you want to set up a collaboration. But I think this is also a big opportunity. But in particular, we need support, and I hope University of Waterloo is doing more of these events on also other topics where we can connect and network.
Yeah, from my perspective, I actually wanted to point out that for different parties, in order to view a stronger capacity, there needs to be a stronger mutual understanding of everyone's role. And I sometimes try to, so I oftentimes do quite a lot of outreach. But at the same time, I felt that every party needs to reach out as well in order for you to try and really establish a strong working relationship. What you want to avoid are collaborations that are purely transactional. Right? And you do this, and I mean everything's delegated. Then you become disconnected in the process. Teams that actually work well together are ones that actually would, let's say for me, I would very much hope to get involved a little bit on like the commercialization aspect or the marketing aspect, like I don't think I'll be dedicating myself full time to become an entrepreneur. But then like at least I need to be doing enough to get things to the point where it will take off. That's something very important. Same from the perspective of working with clinicians, right? I mean, I don't have an MD, right? I wish I had. I'm too old for that now. But like, we just need to kind of like work very closely, okay, with people like Dr. Adams, okay, to try to understand very deeply what are the frontline clinical needs, okay? I mean, like, I don't even mind like job shadowing you, for instance, right? To get that deep understanding, which I think it's important if you wish to become a better tech designer or engineer. And I think at the same time, being a clinician, it would be nice if you can try to dig deeper into the tech aspect, okay, to get a grasp of like what can be done, what cannot be done, what's upcoming. This actually gives you first-hand exposure to like what might be coming up in the future. Yeah. So like I guess like both sides, all parties, they all need to kind of like make a few extra steps to reach out more and build stronger working capacity.
Yeah, no, those are really helpful insights, and just conscious of time, I think we'll wrap things up there, but thank you so much for your thoughts, your reflections, your presentation, sharing about the work that you do, but also opportunities and challenges that and spaces for innovation. So please join me in thanking the panel for their work.
Yes, thank you guys so much, and for the ultimate compliment at the end, saying that events like these are a step towards the right direction for enabling technology to be truly assistive for people in the future. So that's much appreciated. We are going to take a couple extra minutes just to see if there are some questions from our audience. I think we already did have a request to see if we would have a question time. So please feel free to raise your hand if that was you. And I don't mind making the first suggestion, saying that I think understanding and motivation are universal problems, are universal struggles that we all have. So applying them in any kind of field is completely understandable. So it does take people who are going to push that extra level and really try to make the connections that I think you all have demonstrated. So thank you for your hard work in all of your areas of speciality. And I will go to the audience for a question. Yeah, fabulous, thank you.
Thank you for a wonderful discussion. We've had some questions from our online audience centered on a lack of IT infrastructure and personnel in rural communities. In particular, northern communities don't have sophisticated wireless broadband and satellite technology. Does this create a big impediment for digital diagnostics and digital medicine or the delivery of virtual care in general in these communities? And if so, how can we overcome these challenges?
Dr. Adams, that's for you.
Excellent question. The bandwidth issue, the IT connection is certainly a challenge in many communities across Canada, and particularly when we think about innovation on a global scale. The IT infrastructure oftentimes is not sufficient for countries around the world. For the communities in Saskatchewan that we've partnered with, the IT challenges have certainly been overcome. We haven't had bandwidth issues. We've had minimal delay in terms of the telerobotic technology we're working with delays generally of less than 1 second. So certainly we're able to perform the ultrasound exams to the level required. But when we think of even across Canada, the same can be said for many communities across Canada, and particularly on a global scale. I think that this really comes down to questions that are bigger than the IT infrastructure itself, but thinking more about global change and global income and global wealth distribution, and really understanding that health is one of those key aspects which is critical and which unites us as a society. and understanding that IT infrastructure is becoming to be one of those critical elements to ensure health.
Hey, wonderful. Thank you again, everyone, for your time today and for the thought-provoking discussions.
Thank you.
We do have a short break again now, so we will get started promptly at 3:10. But another chance to stretch your legs. Again, a reminder, the washroom is just around the corner to the right here, down 2 short steps of stairs or via ramp if you prefer. So we'll see everyone back for an address from our Minister of Health. All right, everyone, I invite you to take your seats and we'll get started with our next session. Wonderful. It's great to see so many people mingling in the room. You know, that's what we want when we have an in-person element to our events. So thank you for reaching out to each other, you know, and making those introductions and sharing your stories and where you come from and what your interests are and why you came here. So we really appreciate that. I'm glad that to see it happening in the room. Now it is my pleasure to welcome an address from the Honourable Sylvia Jones. She's the Deputy Premier and Minister of Health for Ontario. So please turn your attention to the screen for an address from Honourable Ms. Jones.
Hello everyone, I'm Sylvia Jones, Ontario's Deputy Premier and Minister of Health. On behalf of Premier Ford and the Ontario Government, I'd like to welcome all of you participating in the Centre for Bioengineering and Biotechnology Annual Conference on Health, Technology and Society. As Minister of Health, I have seen world-class and state-of-the-art care taking place across our province, delivered by our amazing healthcare workers. Research, innovation, and technology play a critical role in helping to address patient needs and support better health outcomes. We need to be bold, innovative, and creative to strengthen our healthcare system. And our government is working to build on the spirit of collaboration and innovation taking place across the healthcare sector among its many partners. We recently released our comprehensive strategy called Your Health, a plan for connected and convenient care, which is focused on providing Ontarians with a better health experience by connecting them to more convenient care closer to home, while shortening wait times for key services and growing the healthcare workforce for years to come. Under this plan, we are increasing access to services and healthcare settings near Ontarians, like pharmacies, by increasing the number of assessments and treatments that can be provided by a local pharmacist without a doctor's appointment. And pharmacists are now able to treat and prescribe medications for 13 common ailments at no additional cost. We're expanding the number of community surgical and diagnostic centers, cutting wait times for services like MRI and CT scans and cataract surgeries, supporting virtual care options, and expanding access to home and community care services so people can live safely in their homes. Thank you for everyone participating in this year's conference, for your interest, involvement, and contributions to building better healthcare in Ontario. And thank you to the University of Waterloo's Centre for Bioengineering and Biotechnology for being a leader in research, innovation, technology, and health. You are helping to define what is possible for the future of healthcare and supporting Ontarians' health, wellness, and quality of life. Thank you. Stay well.
All right, now please welcome Ashnoor Rahim to the stage. She is the Executive Director for the Kitchener-Waterloo for Ontario Health Team. So we heard a provincial level of address, and now we're going to go super local. So welcome.
Thank you so much. It's an absolute pleasure to be here. I'm so excited to be able to share some of the work that we're doing, especially in partnership with the University of Waterloo, with all of you today, and to also share our experience and what we think is so important when we think about access and health access in particular. I want you to know I'm just recovering from a cold. I've taken an entire bag of Fisherman Friends before I came on stage, but if I do have to cough, I apologize for it, and hopefully the mic won't destroy everything when I do. So I'm here today to really tell you about the KW4 OHT and what that means, and also talk about some of the definitions and what we think about when we think about accessible care. And as we go through, we'll talk about the healthcare landscape a little bit, talk about what we see as being important factors in terms of access, and then share some examples of some of the work that we're doing that's directly related to some of our findings. So I've talked about this, and I think it's really important that as we go through, if you think there's anything that I've missed or you have any questions, I'm really looking forward to the conversation after. So to begin with, what is an Ontario Health Team and what is Ontario Health? So as you may recall, a few years ago, this government decided to amalgamate all of the different health components under one roof, and they called it Ontario Health. And so before we had Cancer Care Ontario, which really managed the performance and the system delivery of cancer care across the province. We had Trillium Health. We had Health Quality Ontario, which looked at a performance matrix for all of health services. And they really wanted to bring it together. And the goal was that by bringing together these systems of different delivery for healthcare, we could create a better coordinated system. Through that also, the ministry added Ontario Health Teams. And Ontario Health Teams really are designed and focused on integrated care. So at maturity, an Ontario Health Team will represent a series of health providers, which includes family doctors, hospitals, community agencies, long-term care, mental health and addictions agencies, and a whole host of social service agencies under one accountability agreement, one performance agreement, so that the dollars that are currently within each of these siloed systems would come together. And the expectation is that through this model, there would be more coordinated, integrated care across the continuum. And so this is the model that we are trying to strive for through the Ontario Health Team. So the KW4 actually means that we're talking about Kitchener, we're talking about Waterloo, but then also the townships. So Wilmot, Wellesley, Woolwich. And that's really important because in our region, we are about 15% rural. And so thinking about that in terms of health access is very important to the work that we do. This is a little bit about who we are in terms of our geography. So we are bookended by Cambridge, North Dumfries Ontario Health Team, and the Guelph Wellington Ontario Health Team, and we work very closely together. We have within our Ontario Health Team 41 partners. We have hundreds of physicians, primary care physicians. We also have 2 hospitals, St. Mary's and Grand River, and then a large number, over 30 community agencies. What's unique about our health team that I think is so special and really, I think, separates us is our focus on looking at other partners that are important in the health system. So like the University of Waterloo that does tremendous work. I see Stan sitting there, and I'm familiar with the amazing leadership that he has provided us, not just through COVID, but in general around our health system delivery and planning work. We also have a whole host of social service agencies and settlement agencies that are part of our work because we recognize that health is more than just what sits in the hospital and what sits in the primary care providers' portfolio, if you will. And so this broader approach has allowed us to really take a more holistic approach to health and wellness across our communities. So today we're going to be talking about sort of 3 different projects, and I'm so pleased that Jessica Lemon, who's our digital lead, is sitting here in the back because she's the one who's been driving a lot of our online appointment booking work, and it's been tremendous. And then we're also going to talk about the social determinants of health. I feel very passionately about the fact that you cannot look at health without addressing the social determinants of health, and we'll talk about that a little bit. And then finally, we'll end by talking about the Newcomer app. And this is an app that's being developed in partnership with the University of Waterloo, Dr. Catherine Burns, Dr. Edith Law, and we're delighted about this work. So let's start with online appointment booking. So I know that all of us have spent significant time on the phone waiting to book an appointment for something. Most recently for me, I decided that I was going to take up running again because I thought I was 20 years old. And within about a month and a half, my knee was so swollen. And after my family doctor yelled at me, he asked me to book an MRI. So I did what every person would do. I called the MRI number, in my case at UHN in Toronto, and waited half an hour to finally be connected and then be put on hold. And of course, in that process, you know, if you walk away, the second you walk away to get a glass of water or whatever, that's when they pick up the phone and then they hang up. So this is something that we know to be true and that we've all experienced. So online appointment booking was something that was developed and really came out of what we learned, I would say, during COVID more than anything else. As you know, the digital transformation that occurred in healthcare because of COVID and because of isolation rules, et cetera, was phenomenal. We had never experienced that. We didn't even have physician codes for some of the billing that was happening across this. And so really, online appointment booking allowed us to start to, I would say, embrace the opportunity of digital and virtual care. So when we think about that, we can think about, well, what does that mean and how does it benefit? So for example, if I happen to be a worker that is scheduled to work a shift, and I'm working 8 to 4, certainly I'm a physiotherapist, so when I worked in a hospital, I was working 8 to 4 with my patients. I didn't have access to a phone where I could wait, you know, half an hour, 40 minutes for someone to answer the phone and give me an appointment. So the ability to be able to book the appointment based on my scheduled needs is phenomenal because it means that I'm likely to show up. I'm not going to no-show on an appointment. Secondly, it allows me to determine if I need to take someone with me. So I often think about the fact that my 87-year-old mother wants to get her cataracts removed. I need to take her to those appointments. And so rather than my mother who's going to book them and book them for a Tuesday when I have the most important meeting of my life, I can then work with her to book the appointment at the right time. And finally, it allows me to look at specific things that are of interest to me. Location. Does that physician offer something in a language that I would prefer or my mother would prefer? And also in terms of timing. So those are all key components that go into that. From a provider perspective, you can imagine no-shows are huge and they really do cost you if you're a physician that's based on a fee-for-service, like a specialist model. Second of all, you're not going to spend all that time as an admin assistant trying to answer the phones and book the appointment. And you know that admin assistant gets mad when you don't accept the first appointment they give you. And then they try to give you something else and it's always worse. So that's something else. And then finally, just in terms of being able to fix any sort of reminders and pieces that come into your online appointment booking model. So there are huge benefits to the system. And this is something that Jessica and her group have really worked to implement in our region. Right now, Jess, I know that we have over 150 physicians signed off between Cambridge, North Dumfries, and KW4, which is fantastic. And the goal is to certainly look to improve that. Again, improving access through small things that we may think of are as insignificant, but in healthcare, these are mountains that have been climbed. The second thing that we really want to I want to talk about is the impacts of social determinants of health. And I think what's important about this is that we know that there are differences in outcomes based on the social determinants of health, as well as your race and your identity, your visible minority. So, for example, if you are from the Indigenous community or the Black community, we know that many times your outcomes are going to be significantly different than for someone who was Caucasian. And so starting to understand this and recognize it allows us to therefore improve access for so many individuals. Currently within the system, we have care pathways. Some of them are called QBPs, quality-based procedures. So for example, if I get a hip or a knee replacement, I go through a certain process. I get physiotherapy as an outpatient for 6 visits. It doesn't matter if I needed the 6 visits. I might have needed 8, I might have only needed 3, but I get 6 visits. And those outcomes that are expected in those 6 visits, I may hit them, I may not, but I get 6 visits. Similarly, we have other programs like the diabetes programs. If you're a diabetic, you have specific drugs that are provided to you, and then you're attached to a diabetic outpatient program where they will talk to you about healthy food, about healthy diet, about exercise. So I always like to share the example of my father-in-law who at 92 was diagnosed with diabetes. My father-in-law's first language was Swahili, and he also spoke Gujarati, and the language is offered in English. The class was offered during the day when all of us were working, so we couldn't go with my father-in-law. My mother-in-law could have gone, but she didn't speak very good English. And my mother-in-law wasn't allowed to attend, excuse me. And why not? Because it was only for my father-in-law. Who cooked in our house? My mother-in-law. My father-in-law wouldn't have a clue. He wouldn't even make a cup of tea for himself. So the fact that my father-in-law was going to these sessions that he couldn't understand, that meant absolutely nothing to him because he was never going to step in the kitchen, and talked about food that he was never going to eat. My father-in-law wasn't going to eat asparagus. He didn't even know what an asparagus was. Talk to him about butter chicken, about naan, about basmati rice. Those are the things my father-in-law was going to eat. And so these care pathways that currently sit in the system develop a plan that is good for everyone. But is it really? Because the nuances within our system and in our community, look around this room, really means that what we require may be a similar roadmap, but perhaps our milestones and the way we get there will be slightly different. Through Ontario Health Teams, we're being tasked to develop care models. And these are really systems that have multiple pathways and avenues. So for example, if my father-in-law as a diabetic could have gone to a program where they focused on the South Asian community, for example, and could also look at what kinds of foods do you eat? Do you speak this language? We're offering the class in Gujarati, or you can bring a loved one with you. We also have an evening class. How about a weekend class, right? What would you like to sign up for? And this is the list of dishes that we're going to be talking about. Which are the top 5 for you before we start the class so that we can start to develop a plan? So really, care models engage and include the patient, the caregiver, the community member in the delivery of health services. And although for many of you, that might just be a really logical sort of course, that's what we should be doing. In health, it's taken us a while to get there. And I see Stan smiling because I know he knows this, that oftentimes we in health come in with the answer, if you will. And it's hard to be flexible around that because we've built our systems in that way. And so looking at care models, engaging the community in this work is really where health access is moving. This is my drop the mic slide. I would drop my mic except it's attached to my dress. We know that 60% or more of your health outcomes are determined by the social determinants of health. Where do you live? Do you have friends? How educated are you? Do you have access to food? All of these factors play a bigger role in your health outcomes than if I gave you the right drug as a diabetic, even more so. Because if I give you that drug but you don't have access to food, it's not going to matter. I need to know that you can access good, healthy food if you're a diabetic. I need to know that if you have a wound and I need to care for it, that you have a place to live that I can come and deliver that care to, right? I need to know that if you're a diabetic, that you have appropriate foot care and footwear. So these aspects of health, although the majority of them tend to sit outside health, really directly impact health. Through the work of the OHT, we are very focused on the social determinants of health because we are taking a population health approach. So when Ontario Health has a target of reducing the number of lower limb amputations caused by diabetes, that's an outcome that we absolutely want to achieve. But we want to take that back a few steps and say, okay, let's make sure you have access to an endocrinologist. Let's make sure that you have access to a primary care physician or primary care practitioner that can help you with this. But let's also make sure that you have access to the right food, right, around this work. And so really starting to think about that differently. So let's talk about some of the priority projects. One of the things that we did over the summer in order to better understand one of our priority populations, which is newcomers, was really start to do some journey mapping. And journey mapping is a best practice that really helps to follow the patient's experience and capture key elements of it in terms of their healthcare or whatever journey that we're looking at. So for example, we looked at newcomers who had been in the region and in Canada anywhere from 6 months to 2 years. And we talked to them about what was their health journey. And what was surprising was the commonality in what they talked about and the emotions that it elicited. So the idea of, I came here, I was so excited, I was like, oh my God, things are gonna change for me and my family. But then what? I couldn't access a primary care doctor. I didn't know how to get the stuff that I needed. I needed a place to live. Could I get a job? How do I get a job? How do I get a bus pass? How do I put my children in school? These are all elements of the journey that we can help to support and not have to necessarily rely on an individual to provide that knowledge and expertise. So this work actually was just published in Healthcare Quarterly this year. We're really excited about that. But what it did was it gave us a foundation from where to start. And so as we started to look at some of the work that we wanted to do, we took these stories with us. and really they shaped how we developed our work in this year. So there's a couple of key things that I want to point out. One of them is that between 2020 and 2021, we had an almost 300% increase in the number of newcomers in this region. We're just analyzing the new census data, and again, we're seeing the same thing. We know that we're a newcomer-friendly community, and this is fantastic. We need newcomers to improve our productivity, for all of our jobs, et cetera. It's wonderful, but we need to figure out how to adequately support them. And the reason we need to figure that out isn't just because we want them to have the best experience, but because if we don't, we are seeing directly the impact on our healthcare system. So we mapped where our newcomers live, and we were able to identify these 4 key postal codes where we know that the majority of our newcomers come to. And then we took those postal codes, which by the way are marginalized communities in the region. We took those postal codes and we mapped them onto hospital data. And I'm sure you won't be surprised by what we found. So ambulatory sensitive conditions are something that's measured in the hospital. And basically that, by definition, are conditions that should have been managed in the community by your primary care doctor. So they include asthma, COPD, congestive heart failure. These are things that with good primary care can be well maintained in the community. If you show up at the hospital for some of these conditions, you're considered coming to the hospital for the management of an ambulatory sensitive condition. When we looked at the data for the hospital, 60% of the total number of patients that came to the hospital for ambulatory sensitive conditions came from these postal codes. These postal codes represent 19% of our population. 35% of the emergency department visits for mental health and addictions come from these postal codes. Over 33% of the people waiting for primary care, 19% of the population, come from these 4 postal codes. So we need to start to understand what's happening in our communities and helping to support our communities, because if we don't, we're seeing the impact on it on the other side in the hospital. When we look at alternate level of care, those people that are living in the hospital who don't require hospital care anymore, but have no place to go, 33% of them, and they represent 19% of the population. So we're starting to see a trend and really starting to build that relationship between traditional health hospital data and community data. So the 3 projects that we're focusing on that really came from all of this work that we did with the community, with our partners, understanding the data, are around 3 key areas. One of them is primary care integration and governance. And this is very important. You might say to me, well, you just talked about newcomers and all that. How do we end up at primary care? Well, the truth is that we don't have enough primary care docs in our region. And you know, I bet you there are many of you here who don't probably have a primary care doc, or your primary care doc is retiring, or maybe leaving town to go somewhere else, et cetera, and you're stuck. You can go to a walk-in clinic, you can go to the hospital or the Emerge when you need to, but you really need to have somebody who can coordinate your care. And so working with Dr. Sarah Gimble from New Vision Family Health Team, our primary care lead, Dr. Neil Naik, and of course our project manager on this, Rebecca, really trying to understand how do we support primary care. We're working with the Chamber of Commerce, who actually does a lot of really good work in recruitment of physicians and specialists to our region, and trying to understand how do we bring more primary care docs to the region, but also how do we support primary care docs in the region so they can take more clients. What are some of the things that they're doing that they shouldn't be doing, that others should be doing? So for example, one of the projects that we're just starting to look at is putting in community navigators at different primary care offices, so that a primary care doc isn't flipping through his phone or her phone trying to find a Meals on Wheels provider, but knows that he can or she can connect them to a community agency that's just in their office or down the hall, and they can support their client, and not just for the meals, but for other things they might need. Do you need transportation to your appointments? Are you lonely? Do you need to join a social group? Do you need access to food, et cetera? So this is work that's been going on, I would say, and has really developed over a number of years in this region. Dr. Joe Lee, Dr. Mohammed Al-Arakia, and others have been tremendous leaders in this work. And it's really lovely to see this now evolving into the development of a more formalized primary care network. The other piece of work that these folks are doing is related to cancer screening. As you know, during COVID, a lot of our vaccines and other sort of preventative work really fell by the wayside. And so we are behind in cancer screening, and so really trying to figure out how do we allow access for primary care to do this. The second work that we're doing is tied to those 4 priority neighborhoods that we talked about, and that's the neighborhood integrated care team work. And that's being led by John Neufeld from House of Friendship. And we're really excited about this work because it's focused on how do we look at the local delivery of care in this region, and how do we start to understand How are all the providers in this region working together for the betterment of these communities? I've already talked about some of the things that we're seeing in terms of hospital data. So how do we put that on the table and better understand who are the mental health providers in the region? Who are the community agencies in the region? What services does Kitchener provide? What other services are available? Is EMS part of this discussion? Yes. Are the police services? Absolutely. Really trying to understand how do we build healthy communities. Oh, and I should mention, we're so proud in that project, we are working with the University of Waterloo to look at social prescribing and the social determinants of health. And finally, our newcomer app. And this is work that's being led by Dr. Charmaine Dean and also with Dr. Catherine Burns, who I call regularly and I'm sure drive her crazy. She has been an outstanding partner in this work. And this newcomer app really speaks to what we heard from our newcomers. And this is an outstanding project, and Dr. Edith Law is actually doing some of the research around this. So the newcomer app project, we talked about the fact that we've seen 3 times the number of newcomers come in. And what we know about our newcomers is when they come, they're generally healthier than they are a few years later. And that is directly tied to the social determinants of health. They often develop chronic disease and other things that they didn't have before, and it's because they're not connected to good health systems. And so really trying to think about that trend and what does it mean, and really try to deliver better services. The other thing we know about our newcomers is they're highly intelligent, and they actually have a higher level of education than many people who live in this region. And they're very tech savvy. And so how do we start to use technology to really inform and allow them to navigate the system more independently? How do we build in translation services? How do we ensure that they can access those services 24/7 so that you're not a shift worker who's trying to get to a settlement appointment while you're trying to also earn a living for your family? So the project has a couple of different key overviews, and I'm just going to try to speed up a little bit, but ultimately the desire is to create a self-navigation component to this app. And so the first part of the work is really starting to understand the newcomer experience. And what Edith and her team are doing is taking a human-centered approach to this and building in work around what factors influence your journey in the first year as a newcomer. And what's really important about this work is we're doing it with settlement agencies. Because the truth is, if you're a university researcher and you go in to speak to a newcomer, 1, you have not built that relationship. 2, they don't trust you. And 3, the truth is you're not getting an authentic response. If they don't understand your question, they're not going to tell you that I have no idea what the heck you're talking about, right? They're just going to answer you the way they think you want to be answered. And so by working with our newcomer agencies like the YMCA, like Kitchener Downtown Community Health Center, which provides a large number of primary care services for newcomers, we can start to embed some of this work into the settlement agencies. And they can help us to actually get the right information. The goal here is to actually improve the factors related to the social determinants of health, and thereby increase the experience and improve the overall health of our newcomers. So phase 1 of the project is currently underway right now. It's really sort of a gathering phase. I'm learning a lot from Edith about all of this. I sat through a lecture of hers a few weeks ago. It was fascinating. But really, as I understand it, we're taking a whole bunch of different sort of cards that express different emotions, translating them, because what does that mean in Arabic? What does that mean in Cantonese or Mandarin? What does that mean in Spanish, etc.? And then working with the newcomer agencies to figure out how best to deliver these sort of questions and capture these stories. Based on this work, we'll build a prototype for this app, and then, of course, work with our communities to say, does this make sense? Is this what you're looking for? Should we use an emoji or something else to express this, etc.? And we're very excited about this. What's amazing about this as well is that the goal of this project is to share whatever we develop with not just other regions, but provincially, internationally, so that others can have a better experience. So that, in a nutshell, is some of the work that we've done. That's a little bit about what the KW4 OHT is and some of the things that are important to us in terms of the social determinants of health, in terms of improving access to health services. I'm happy to take any questions that you might have, and thank you so much.
Absolutely, thank you. I am so grateful to end our day with this presentation from you. I think it perfectly demonstrates how we've been taking what we've learned and actually making change. And I'm so grateful that there is a body like the KW OHT that is going to bring together, and amalgamate these care services, because like you said, it needs to be done to be able to deliver good health to people. And it's not just the responsibilities of our general practitioners to deliver this. When we start reimagining how our system is delivered, it's an easy answer to say, oh, okay, that's now the GP's job. Now, that's how we get burnout in our system. So bringing together all of those care providers is it's so exciting to see. And I'm really grateful that you're doing it. So
Thank you.
Yeah, thanks for illustrating those projects as well. So please, let's have some questions from the audience, because if you live in this area, this group definitely pertains to you. So I'll open up the floor. Awesome.
With the doctor shortage, it's like a long-term fix because there's no quick solutions. What can you do to somebody who comes here and can't get a family doctor?
So that's a great question. And the question, I don't know if you heard it, but was, what do you do if you can't get a family doctor? So right now, there's nothing you can do, which is a terrible answer, but it's the honest truth. There are a number of walking clinics that are that are up, and you can attend certainly one of those, but it's not coordinated care, right? And it certainly doesn't allow someone to follow your care. What we're seeing happen more and more, and we saw this in particular over the Christmas time when a lot of children were sick with RSV, was that parents came to the eMERGE. They didn't have a choice. One of the things that we're trying to do is to work with the province. For example, over the holidays, we had COVID cough and flu clinics that were set up in different neighborhoods. So in our priority neighborhoods, we actually established a COVID cough and flu clinic. And what we did was we translated all of the documents for these clinics into our top 5 languages. And we shared that with Cambridge, and they shared their top 5. And we did this with the region of Waterloo, actually, because they gave us the space in these regions to run these clinics so that families could come, so that you didn't have to pack a lunch and head to the eMERGE, right? So you could go to these clinics and actually get the care that you needed for your loved one, often your child or what have you. So certainly looking at how do we make it more accessible in the interim while this is being looked at. We also know that there are, in the federal transfer of money that just happened with health, we know that there are going to be dollars released around this. And so we're working very closely with our primary care leadership to talk about, it's fine for money to come to the primary care office, whether that's a nurse-led outreach team or a family health team or what have you, but how do you share that with other physicians? Because not every physician has a team. In fact, there's very few. Of the 200 and some odd physicians, less than 45 are in team-based care. So the goal is to figure out how do those physicians that are, in essence, working independently without a team have access to the same services. And that's some of the work that the OHT has been doing. A great question. I wish I had a better answer for you, I swear.
Thank you very much. And we have time for another question.
Thanks for a great talk. We do have one question from the online audience. What role are patient partners playing within your team?
It's a great question, and I'm glad you brought that up. So in our OHT and in our steering committee, which really provides us with guidance, we have a large number of community members as part of our work. Within the mandate of the OHT and the Ontario Health Team is an expectation that this work will be co-designed by our communities, and that is very important. So part of what I would say a significant portion of the work that we're doing to date, just like with the patient journey mapping, is about understanding the community and their needs. And I'll tell you, from my own personal experience, I've learned this the hard way. When I worked in St. Jamestown in Toronto, I was convinced they needed primary care doctors. And then when we created this whole fancy model for St. Jamestown and we took it to the families, they said, we really need a dental van. We're fine to go to the hospital and go to the eMERGE when our kids get sick, but we don't have access to dentistry. And we were like, but we just spent all this time. And they're like, but you didn't ask me. And so really now it's about what is the need in the community. And so, for example, working with those 4 priority neighborhoods that we talked about, we've been understanding and working closely with the grassroots agencies that are actually working with those community members. I know I've spent time walking around those neighborhoods and trying to understand, how far is it to a grocery store for you? Where's the bus? Do you have access to housing? Where's the school in the neighborhood? And really understanding where the communities live, if you will. And then figuring out, okay, how do we wrap health services around those? So it's almost turning it upside down, if you will. and including the community in that. Thank you for the question.
And we have another one.
Stan.
Yes, more of a comment than a question. First off, fantastic presentation.
Thanks.
And admire and appreciate your passion. My comment is that KW4 OHT is an outstanding organization and coalition. Everybody is as dedicated and as passionate as Ashnoor. And for the students in the faculty room, I think it's really critical to understand that there's an opportunity to really be able to work with our community like a living lab. That there are folks there who can help us be able to translate, for newcomers, for example, as a population, but they want to support us as much as we want to support them. And it's growing, and we appreciate Catherine Burns' leadership and Charmaine Dean. The University of Waterloo can do so much, not just in research, but also with co-op placement, work integrated learning. We can do something really unique here. And the president laid it out at the very beginning, right? If we're going to lead at the interface of health, technology, and society, this is the partner that we want to have, and this is a unique opportunity. And again, we just want to thank Ashnoor for her leadership and again, the amazing work that the KW4 OHT does. It really is spectacular. And I encourage everybody to learn more about it in this health space, because all the things that she's outlining, there are a million questions that go along with it. So if you have the time, the talent, and expertise, this is the place, this is the group, and the University of Waterloo and KW4 are outstanding partners. So thank you, Ashnoor.
Thanks, Dan. I appreciate that. And I have to say, the love right back at you, because the truth is, I feel like a kid in a candy store with the University of Waterloo. I really do. I think I sent 4 different MOUs to Catherine a few weeks ago. I did, actually, about, hey, can we do this? Can we do this? How do I do this? And, I sometimes feel like I've just hit the lottery with the University of Waterloo. And I genuinely mean that, because the opportunity to bring health and research and best practice together is phenomenal. And if I could tell you how excited our settlement agencies are about being approached to be part of a research project, I mean, they were blown away. And I just think the learning for the University of Waterloo, as well as like, well, what do you mean I'm not going to do this like on my own in my little runway, right? You want me to talk to settlement agencies? What? And it's been phenomenal learning. So I think that on both sides, the ability to build that relationship, I mean, I just think this, like, the sky's our limit here. So I'm really excited about it, and thank you.
Okay, I think that is a wonderful place to end our day. I'm so proud to say that this discussions today have achieved, if not at least on the road to achieving our goals of translating knowledge on accessible care. So thank you so much to all of the speakers that have been here today. Thank you to our audience members. I hope that you will join us again tomorrow as we focus on health data and the elements of safety. So good evening to everyone and take care.